Welcome back to Clean Med KE. Today, we are diving into the clinical roadmap to understand nephritic syndrome. Medical disclaimer, this video is for educational purposes only and does not constitute medical advice. Please consult a healthcare professional for diagnosis or treatment. Let's start with the basics, the glomerular filtration barrier. Think of this as the kidney's high-security checkpoint. In its normal state, it's a sophisticated three-layer filter: the fenestrated endothelium, the basement membrane, and the podocytes with their filtration slits. Its job is simple but critical. It allows small molecules like water, sodium, and urea to pass through, while strictly blocking larger items like red blood cells, white blood cells, and large proteins. But what happens when that checkpoint is compromised? In nephritic syndrome, the core mechanism is inflammation that physically damages the glomerular basement membrane, or GBM. When this barrier loses its structural integrity, we have a breach. The consequence is that things start leaking out that shouldn't be there. You'll see red blood cells, leading to hematuria, white blood cells, causing sterile pyuria, and proteins, though usually in a subnephrotic range of less than 3.5 grams per day. It's essential to distinguish this from its counterpart, nephrotic syndrome. Think of nephritic as the bleeder and nephrotic as the leaker. While nephrotic syndrome is characterized by massive protein loss and severe edema due to podocyte injury, nephritic syndrome is defined by GBM injury. The primary clinical signs you're looking for in nephritic syndrome are hematuria and hypertension. Under the microscope, nephritic urine shows red blood cell casts and acanthocytes, while nephrotic urine is more likely to show fatty casts and oval fat bodies. When you're playing detective at the bedside, look for the rule of 7. These are the 7 key macroscopic clues of nephritic syndrome. Hematuria, often described as dark, cola-colored urine. Hypertension, caused by the activation of the Ross system. Proteinuria, though again it's typically mild. Azotemia, which is an elevation in BUN and creatinine. Oliguria, or decreased urine output. Edema, which is usually mild and found around the eyes or ankles. JVD, jugular venous distension, from fluid retention. Now, we look closer with a urinalysis. We're looking for 3 specific proofs. First are dysmorphic RBCs, or acanthocytes. These look spiky and thorn-like because they've been physically crushed while squeezing through that damaged GBM. Second are red blood cell casts, cylindrical clumps of cells that are highly specific for glomerular disease because they take the shape of the renal tubules. Finally, we look for sterile pyuria, where white blood cell counts are high, but tests for infection are negative, proving the inflammation is immune-mediated, not a bacterial UTI. So what's causing the damage? We can categorize the suspects into 4 main groups. Immune complex deposition, where antibody-antigen complexes get stuck. Anti-GBM disease, where antibodies directly attack the membrane. Post-immune/ANCA, where immune cells attack small vessels without leaving many complexes behind. Hereditary, which involves a genetic structural defect, like Alport syndrome. We have to be on high alert for the danger zone, rapidly progressive glomerulonephritis, or RPGN. This is a severe, rapid decline where a patient can lose 50% of their kidney function in just days or weeks. The hallmark sign on a biopsy is the presence of glomerular crescents. These are formed by fibrin and macrophages proliferating in Bowman space, creating a crescent shape that physically crushes the glomerulus and stops filtration entirely. Any severe nephritic syndrome can progress to this emergency state. To narrow down the cause, we check the patient's complement levels. If C3 proteins are low, it means they've been consumed by the immune response. You can use the mnemonic PLM, or please lower my C3, to remember the big 3: post-streptococcal, PSGN, lupus nephritis, and membranoproliferative, MPGN. If C3 is normal, you're likely looking at IgA nephropathy, good pasture, ANCA vasculitis, or Alport syndrome. Each immune complex disease has a unique visual signature. PSGN typically appears 1 to 3 weeks after an infection and shows lumpy, bumpy deposits. IgA nephropathy, the most common worldwide, shows up just 1 to 2 days after a respiratory or GI infection. Lupus nephritis is known for wire loop lesions, and membranoproliferative, or MPGN, is famous for a tram track appearance, where the GBM actually splits. Next, we have the autoimmune aggressors. Anti-GBM, or good pasture syndrome, involves antibodies attacking collagen in both the kidneys and the lungs, often presenting as a young male coughing up blood while having blood in his urine. On the other hand, ANCA vasculitides are pauci-immune, meaning they trigger systemic inflammation in small vessels, but don't leave behind antibody deposits on a slide. Don't forget the genetic outlier, Alport syndrome. This is an X-linked mutation causing a defect in type 4 collagen. It has a classic clinical triad: can't see, can't pee, can't hear a bee, referring to eye issues, progressive renal failure, and hearing loss. On electron microscopy, the basement membrane has a distinctive basket weaving or banana split appearance. This is where everything comes together. If we perform immunofluorescence on a biopsy, the pattern tells us the diagnosis. A smooth, continuous, linear glow means anti-GBM disease. A granular, scattered glow confirms an immune complex disease, like lupus or PSGN. And if there is negative or no glow, that's your pauci-immune ANCA vasculitis. Finally, how do we treat it? It's a 3-step approach. First, treat the underlying cause and symptoms, like antibiotics for infections or diuretics for fluid overload. Second, suppress the inflammation with high-dose corticosteroids or long-term immunosuppressants. In emergency cases, like RPGN, we use plasmapheresis to physically filter out and remove the attacking autoantibodies from the blood. That wraps up our roadmap to nephritic syndrome. Thank you for reviewing this complex topic with me today. If you found this visual synthesis helpful, please like, share, and subscribe to CleanMed KE for more clear, structured, and clinical high-yield medical education. I'll see you in the next case.